Welcome back to Mysteries of Health Under a Lens. If you are new here, I am a doctor currently completing my residency in pathology, and my goal is to help you understand what's happening at the microscopic level. Just a quick disclaimer before we begin, this video is a professional medical review intended strictly for residency preparation, lab analysis, and objective diagnostic education. I will be focusing purely on the high yield biopsy findings and underlying disease mechanisms rather than clinical management or treatment protocols. Please do not use this information as a replacement for medical advice. So, today we are going to break down a new topic, that is approach to bone tumors. Alright then, let's get started.
Formed the foundation of this series of bone tumors. She told you about histology, normal histology of bone. Then she took you through a lot of radiology images as well. Her and Dr. Amit Janu both were there. And those who attended it would definitely benefit from that lecture. And it would be easy for people who have attended that to understand the further build up, like today's is approach to histopath diagnosis of bone tumors. It would be easy if you had attended those. It was really an excellent collection of radiology images and the normal bone structure as well. So today what we would do is, this is just an approach. So it won't be an um, extensive in-depth description or presentation of any one particular bone tumor, but essentially how to go about to diagnose a certain bone tumor. That is what we would be discussing today when it comes to approach of histology diagnosis. And we have Dr. Prakash Nayak here. He is a professor and orthopedic surgeon, and we interact very closely, almost on daily basis at Atomic Memorial Hospital. So we really know what language we talk to each other. I'm really happy that Dr. Prakash is here, because from time to time I'll be asking him the relevance of our histopathology diagnosis as well, which will make more sense in the larger context. And I'm hoping that Dr. Amit Janu, who is a radiologist who you heard on Tuesday, would stay here for a longer time too. So let us begin. Right. Uh, Primary neoplasms of bone are actually rare. They amount only 2.2% of all the tumors. They are less common, 10 times less common than the soft tissue sarcomas. They have bimodal age presentation. Children are frequently affected, but they can also occur in adults at age of 60. Before even we begin with diagnosing the bone tumors, there are certain things that we should really know. Um, like, what are the categories of bone tumors? What is possible within the spectrum of bone tumors? And the basic categories are the tumors which are osteogenic, like those which can produce osteoid matrix, the cartilaginous tumors, Ewing sarcoma, metastatic tumors, hematolymphoid tumors, vascular tumors. Then there are certain other rare fibrous neural adipocytic tumors, and very rare tumors like chordomas and adamantinomas. So you can find any of the bone tumor on your microscope at any day. And it's very important, just like any other tumor categories, you should know the entire spectrum that can happen in a particular tumor. So out of these are the five big fives that I would say: that osteosarcoma, Ewing sarcoma, giant cell tumor of bone, chondrosarcoma, and metastatic tumors of the bone. These are big fives when it comes to bone tumors. Now, why are we scared of the bone tumors when it comes to the diagnosis of bone tumors? If I ask you to raise your hands, like who are scared of them, I think I would be the first one to raise my hand. And why is that? The reason is that there is a massive overlap between reactive, benign, and malignant lesions or tumors of the bones. There are overlap between many, many different types of tumors. They can look like one another, and wherein their management is completely different. Then our diagnosis, histopath diagnosis is heavily reliant on radio imaging. There is no substitute for multidisciplinary approach in the diagnosis of bone tumors. The H&E stain, fortunately or unfortunately, is still the cornerstone of diagnosis of bone tumors, wherein the ancillary diagnostic techniques are not so much useful as they are in the soft tissue tumors, right? This first point is very important, that there is a overlap between reactive lesions, benign lesions, malignant lesions. A reactive lesion like say fracture callus or certain benign conditions like myositis ossificans can mimic osteosarcomas so closely that it is a big trap that is laid down everywhere for the pathologist. And it really, really, this problem, I think benign versus malignant, I don't think in any other oncologic system this problem exists so much as it exists in bone. So the lesions, we are fought with lesions with equivocal histological features. Like we don't know what category of this tumor it is, whether it's a tumor or not in first place. Okay, so it's a big challenge. And why is it important that you diagnose a certain bone tumor correctly? So, Prakash, this slide, maybe if you want to, give your inputs on this, and if there is any other information that you can give on this, would you like to?
Sure.
Like, why
So,
is it important to diagnose a certain bone tumor accurately?
yeah. So few challenges which we all face. So vast majority of most bone tumors, forget whether they are benign or they are malignant, when we see a patient come to the clinic with a pathology that's affecting the bone, the vast majority are young. They are in the peak of their growth age, usually around the adolescence, and in the most active years of their lives. So there's a big responsibility first, even before we go to treatment, to know that we are not under or over treating anyone. For a benign lesion, most often than not, they come in two categories. Leave them alone and they'll heal themselves, or you operate and you curate them. We're not much worried about these because there's not much harm in the long term that one can cause, apart from, of course, performing a surgery that's futile, that's unnecessary. On the other hand, if it is a malignant one, you don't want to miss it. At the same time, a benign looking one could be a mimic of something more sinister, and you don't want to miss out on those. And why do we worry? Because when you label a tumor as an osteosarcoma or an Ewing sarcoma, which seem very common, which seem very classic, but which can mimic many other tumors, a patient and his family have to at least commit 9 months of intensive treatment, which includes chemotherapy, surgery, and sometimes radiation. Many of these treatments are life altering, which means they can get an endoprosthesis, up to 3 months of chemotherapy before surgery, up to 4 months after surgery, could render many of the young boys infertile for life because ifosfamide and some other chemotherapy can cause azoospermia in over 50% of kids. Some of them may have cardiac toxicity, nephrotoxicity, and none of these, even if the percentage is very small, are without, so no, there's no free lunch. So there's a big onus on us to really diagnose them correctly, not only to not undertreat them, but also most importantly, not overtreat them. Because at the bottom, no matter how bad the tumor is, remember when they're presented and treated at the right time, 70 to 80% of them go on to be cured for life. So it's a big responsibility at the desk or at the feet of our team of pathologists. Over to you.
Great. Thank you so much. So such a word, such a wisdom coming from the clinic directly, Prakash. And not only that, so even within the category of malignant tumors, all these tumors are treated differently. The approaches are different. For example, the osteosarcoma, we would treat with neoadjuvant chemotherapy followed by surgery, whereas chondrosarcs are not deemed very responsive to chemotherapy. So that does not come into the picture till maybe it has undergone dedifferentiation. Even sarcoma has its own protocol of treatment. Then metastasis treated according to the primary site, depending upon whether they are treatable or not. And as Dr. Prakash said, the bottom line remains that if the patient undergoes surgery, it's invariably morbid. So this one slide just tells you that how much it's important and how much onus we carry when we are dealing with a biopsy from a bone or even a resection for that matter. And here comes the importance of the concept of a team. Histologic diagnosis for us is never standalone. Diagnosis is not made only looking at the pink and blue stain, that's a H&E stain of ours, and immunohistochemistry, those are the brown images for us. It is never like that. And I really like to emphasize this every time I talk about bone tumors is that the important fundamental team that makes the diagnosis of bone tumors is these three Devs, okay? The three pillars of diagnosis. One is, as Dr. Prakash said, the orthopedic surgeon himself. Then comes the radiologist, and then us, the pathologist. And unless all three are in concordance in their thought processes, the ultimate diagnosis cannot be arrived upon, or if there is any discrepancy, these three should be in sync with each other for discussion. Now, let us come to a real clinic. There is a patient here. This is the real patient's journey. What happens? Like he has a certain lesion which he thinks is creating trouble to him in terms of swelling, terms of pain, and then he undergoes, he comes to an orthopedic surgeon's clinic, maybe through his general physician's referral. Now, what happens in the clinic? A detailed clinical history is taken. Examination happens in the clinic, so we know the age of the patient, the pain if he has or not, nature of the pain, duration of the symptoms, fever, history of trauma, any other illness, previous treatments, any other associated conditions, any other site of malignancies. And then obviously a lot of information is gathered from this history and the clinical examination. At this point, the radiology investigations are also asked for, and also laboratory parameters like serum electrophoresis, serum tumor marker levels, alk phos levels, and the other routine laboratory investigations. At this point, when the radiology happens, this is something that is a recap of what we heard on Tuesday, that every member of the team, not just obviously the radiologist, but every member of the team should be aware of this fact that which bones in the body have which tumors in more frequency compared to others, and also within a given bone, which part of the bone carries the risk of development of which tumor. If it is a metadiaphyseal region, it's the osteosarcoma, right? If it is in the cortex, osteoid osteoma, and so on. So there are so many specificities that certain tumors tend to follow, although in medicine, there is nothing like 100% rule. But these are the rule of thumb, you can say, which every member of the team has to understand. And the radiologist would go through this long list of parameters that makes them help decide what this tumor is and what could its nature be. And this is what we again heard. So it begins with an precise anatomical location, the size, the matrix composition, the nature of zone of transition, the pattern of bone destruction, infiltration of the medullary cavity, and so on. So, and the nature of periosteal reaction, whether the lesion is single or it is multiple. So there are so many parameters that the radiologist looks at. At this point, if Dr. Amit Janu is there, I would Dr. Amit, if you're there, would you like to add anything to this list?
Yeah, madam. Basically, these are the things which we will try to evaluate. And the most important thing is that we have a lot of clinical information that we should utilize, and then subsequently what is the location within the bone, and even if it is within the same bone, what part of the bone is actually involved, and then we will go into the characteristics, whether it is within the what is the kind of matrix it is, what is the margin it is having, whether it is having soft tissue components, whether there is a periosteal reaction which is solid one, or it is having an incomplete one, whether it is incomplete, whether it is Codman's, or it is multilaminated, or it is spiculated, sunburst, all those things. So it will help us in triaging our lesions into benign and malignant category. And if it is malignant, whether we can classify them based on the matrix, whether it is osteoid, or it is cartilage, or it is non-matrix producing tumors like lymphoma, or it is an Ewing's or something like this. So there is a lot of these things which will help us to triage these lesions better. So we can rule out the lesions which are no-touch lesions, and we can say these are the lesions which are actually benign, aggressive, in which there may be some other treatment like ablation, these that can be done based on these things. And there are some tumors in which multimodal treatment is required, and that has to be proven with the biopsies, whatever the radiology will say. So we have to triage these lesions in that way.
Right. Excellent. So it is, you have really explained this so well on Tuesday. So the radiologist and the pathologist, Dr. Amit, we speak such different languages. Yeah, don't you agree? We see things very differently. And we are asked different set of questions by the orthopedic surgeons, right? But it all becomes meaningful when the dialogue is made, and everything is merged with clinical.
I think one question is very common, that is whether it is benign or malignant. That is both of us. And Prakash will agree with that. Ultimately, when we don't have any name to give, at least they want whether we are dealing with something which is benign or something which is malignant. And I think we should be able to differentiate between these two.
Correct. So this is the gray world of the radiologist, and this is the colorful world of the pathologist. Okay, and this is obviously a macroscopic image of the bone, and we are going down onto the cellular level, and we are watching what the tumor is doing at the microscopic level. So it's a totally a different world altogether, but it's beautiful how things also get in sync with each other, and how findings are concordant, be it clinical finding, radiology, and the pathology findings, and they should be concordant when we are set to treat that particular patient. So as Dr. Amit said, what is important at this stage is to identify no-touch lesions. So those lesions do not end up under the microscopic lens. These patients are not touched with the biopsy, no biopsy is taken, and there is a long list of these lesions, and the radiologist would filter them out for you, thankfully. So they will we will not be able to, or we don't have to really look at them and make the diagnosis of these lesions. And herein, when the do not touch lesions are ruled out, a decision to perform a biopsy is taken. So are you understanding the flow of the patient from the clinic to he has now come to the biopsy stage? And here you get the tissue. It is a J needle biopsy, sometimes a resection. It comes to your desk for reporting. That is where you are right now. You are viewing that biopsy while you are listening to the history. So this is the real life scenario that happens in every pathologist's office or workstation. So we are listening to the history, we are viewing the biopsy, we are registering the morphology of this tumor as we are listening to the history, right? And then you make up your mind as to, fine, this lesion looks like this tumor has these characteristics. And now let me go back. So many times I actually go back to the clinical details to then integrate with the morphology much, much better. Then I listen to the clinical details again, and I review the radiology on the EMR. I don't read the images. I'm so sorry, Amit. I should not say that I read the images, but I look at the images and I look at the radiology report. And why do I do that? That is because first and foremost is that it is easily accessible in our electronic medical record. It is absolutely a privilege to have these at the click of the button, that you can open the images. So even if I'm not a radiologist, I do look at all the radiology images. And here comes the question: how much radiology should a pathologist know? Right? So Dr. Amit would say you need not know anything. Is it right, Amit? Is it correct that we should not
About
know
at
any
least
radiology?
no. So, madam, the main thing is that we should know the terminologies. Definitely, what kind of terminologies we have. Like when we call it is something as an incomplete periosteal reaction, when we call it as a soft tissue, what it mean. When we say it is an well-defined margin or geographical margin, what it means. When we say permeative, destructive, what it means. So, if we have the same language, at least it will give us some clue. We are going in which direction. We are going in a direction where we think it is very aggressive lesion towards a malignancy, or it is an aggressive lesion towards an infection. So I think that differentiation, if it is there, then it will be much easier for the fellow orthopedician also, and the pathologist also. Okay, yes, we are thinking in this particular aspect. Now these are things in front of us, whether they are matching. If we club them together, the information, whether they are matching with each other. If they are not matching, what could we could do next to match them?
Correct. So never ever think that you are not supposed to read radiology images. Of course, you are not the master of it, but you should know enough to ask the right questions when there is, and enough to recognize that there is a discrepancy between what you are seeing on the radiology images and what you are seeing under your microscope. That much radiology you must know, and you learn along the way when you work closely with orthopedic surgeons and the radiologist. Now for the pathologist, the journey through the Haversian canal begins. Okay, and how do we do? Now this is the approach. We have this. So decide, first of all, decide if the lesion is neoplastic or inflammatory or reparative. As I said, this in itself can be a problem in bone. If it is neoplastic, you decide what is the cell type and is it producing any of its product. And when I say product in the context of bone tumor, we are talking about the matrix. And that matrix would be, for example, osteoblasts produce osteoid matrix. The chondrocytes would form the chondroid matrix. Malignant round cell tumors, on the other hand, would not have any matrix. Giant cell rich tumors, again, they wouldn't have any matrix, but their cell composition would be totally different. Malignant round cell tumors would look totally different. Then you should see how are the tumor cells. Is there any anisonucleasis? Is there any atypia? And then is there any other cell type rather than the osteoblastic, chondroblastic, round cells? Do the cell type, do the cells have any other morphology which would suggest that they could be, non-osteoblastic, non-chondroblastic, like could they be epithelial, could they be lymphoid, could they be of endothelial lineage? All these thought processes should come to your mind at the first glance. It might just take about 2 seconds for you for the brain to process this information, but it should by default go through your mind at the first glance of the biopsy. And once you have decided the cell type and its product, the next thing that you have to do is decide, what is there any cellular atypia? Are there any mitosis? Are there any atypical mitosis? Is there any sign of invasiveness of the native bone? Is there any necrosis? Because all these features are helping me to decide with what is the lineage of this bone tumor. And then from point 2 to point 5, it is helping me to decide whether this lesion or maybe a tumor is benign or it is malignant. That is the thought process as soon as I put the slide across onto the microscope. This obviously in the light of the clinical presentation and the radiology. I am not looking at it blindly. Now this is case 1, 14-year-old female, and she has a swelling over ankle. So Amit, can you just quickly describe this?
So what we are actually seeing is that there is an permeative kind of destruction. Why I will say permeation? Because we don't see where exactly the lesion is going into the bone. Sorry. And what we are actually seeing is that there is a periosteal reaction. The periosteal reaction is multilaminated. and it is incomplete. And then there is a soft tissue around the bone. So if we see all those parameters, then it looks to be aggressive. Aggressive in the sense that it is not looking like an typical infection as per se. There looks like there may be a tumor, but definitely this is what we see on the X-ray. Regarding that,
Yeah.
there looks like there may be some matrix that is the probable osteoid matrix. I'm not very sure of it. But if we
Here?
have an MRI there, then definitely we will have much more better clarity in differentiating these aggressive bone tumors to differentiate between whether it is typically an osteoid, and if it is osteoid, whether it is a chondroblastic OGS or it is a fibroblastic OGS. If it is not matrix producing, whether it is a round cell, but what could be, whether it is fitting more towards a lymphoma or it is more towards an Ewing's. So this is
So
how
in this
so it will be
case,
an aggressive lesion, and we need to rule out primary malignant bone neoplasm.
Right. Okay. So this is the biopsy of this lesion. Now, I will just describe this lesion, and then the message here is that now this biopsy has this pink matrix. Okay. So the question that you should be asking are again three questions. Matrix, is it there or no? What is the cell type? So is the matrix there? What do you mean by matrix? Matrix means a material that is present maybe as a forming a structure or a scaffolding to a particular tumor. And in the context of the bone tumor, we are talking about either it is a osteoid matrix or is it a chondroid matrix. So this pink looking material is osteoid matrix. So those students who have not seen the osteoid, just understand this, that is pink hyaline material. This is formed by these cells which are here, and this is what we call an osteoid matrix. So even in this image, we are seeing this pink material. It is starting to look a little blue because it has started to mineralize. That is why it is blue. Okay, so this is the osteoid. And now look at the intervening cells here. Those are the real beasts. This osteoid is not malignant. It is not malignancy. It is just an amorphous material. What is the beast? A live beast here is the cells. Okay, and look at the cells. How are these cells? These are large cells. They are large. They have large nuclei which are hyperchromatic. There are mitosis here, and the cytoplasm is eosinophilic. So this is how the osteoblasts look like, and in this case, they are malignant. Look at the anisonucleases. The one osteoblast is not looking like another. Some cells are very big, some are small. They are mitotically active. They are trying to produce osteoid. So with that radiology image that you saw, this is a classic conventional high-grade osteosarcoma. And this becomes your baseline diagnosis of conventional high-grade osteosarcoma. Okay, and based on this, you should realize all, or you should learn about the variations in osteosarcoma diagnosis. But this image is your, go-to image or your index image, as you can see. So an osteoid producing tumor, there is osteoid matrix, the cell type osteoblastic, which is showing clear signs of malignancy in terms of the nuclear features, mitotic activity, right? So this is a high-grade conventional osteosarcoma. So osteosarcoma is a sarcoma with osteoid production. It affects.
Can we go back into the X-ray?
Yeah.
Yeah. So what we are actually seeing was looking like an osteoid matrix, the lower down that we have discussed, and it is an aggressive. So if we combine aggressive with an osteoid matrix, it is osteogenic sarcoma. This is how we will approach in our day-to-day.
Yeah.
If our pathologist will say, yes, we see the osteoid matrix, then there is no doubt, and there is no ambiguity between the diagnosis, and it is an easy, straightforward process.
Absolutely. So now what I said earlier, if instead of this image, I, for example, saw a round cell tumor. So what do I do then? Then I run back to Dr. Amit. Okay. And I would say, my God, you have called this osteosarcoma. Is it really? Okay. And those are the discrepancies that you need to highlight, you need to discuss out. And that is what I was saying, that, you should all be on the same page. Here it is perfectly matching with the radiology impression of osteosarcoma. So this is a high-grade conventional osteosarcoma. Aggressive malignancy with 40% mortality, treated with neoadjuvant chemotherapy followed by surgery. Now, this is yet another another case. So, Dr. Amit, do I have the radiology? This is a 33-year-old male, and he has pain while walking. I forgot to put the X-ray here, but this is a well-defined eccentric and expansile. So, Amit, I'm just reading out the report which was there on our system.
Yeah,
Okay,
madam.
and we
Thank you
all
so much.
know this.
Actually, I think X-ray is equally crucial, and that's
I
why
know, I
sometimes
know.
we will say that both X-ray and MRI should be there to make a diagnosis. Like
Yes,
when
yes,
you have a
yes.
HNE, something else is not there.
Yeah, yeah.
But what
No,
we
I
are
agree.
seeing is that there is a edema that is there,
Yeah,
and it is relatively well
this is
defined.
the,
There is no soft tissue that we are seeing it. The cortices are actually maintained. So it is
yeah.
some lesion which is looking into benign aggressive category where there could be
Mhm.
some benign aspect, but because of the edema, which we call it as a benign aggressive lesion. So
Yeah.
in this, we want to rule out typically the chondroblastomas and the osteoblastomas, but
Mhm.
it looks like that there is a sclerotic lesion which has been mentioned on the description. So if we see
Yes.
the sclerosis and then edema, we will favor towards an osteoblastoma rather
Mhm.
than an osteogenic sarcoma. So this is how we will
Right.
frame our report, and then we will see whether it actually it is matching with our path report.
Okay, so now comes the problem. So Amit has not called this osteosarcoma as he was very confident in the first case. Okay, here he has a doubt that this may not be as malignant as osteosarcoma, but something which is locally aggressive. And here comes the biopsy. Now, what would you say? What are you seeing here? Indrajit, any thoughts on this? This was a very difficult case. All of us know this case very well. This was so problematic, and that is why the importance of a multidisciplinary meeting and discussion. So I will just take this description forward. This is a matrix. Can you see the matrix? Indrajit, do you agree that there
Yes,
is
uh,
matrix?
yes, ma'am.
Yeah.
I can see some osteoid matrix scattered all over
Osteoid
the.
matrix, absolutely. It is full of osteoid matrix. So this is a primary osteoid producing bone tumor. Now the issue is cell type. And of course, I am seeing cells which are osteoblastic. Yes, so these are
Yes,
very
ma'am.
similar to what you saw in the first case. Now the question comes whether it is benign or malignant, and that becomes a very critical issue because the radiology is locally aggressive. Okay, but when it comes to the biopsy, it is not, it is neither outrightly malignant nor it is outrightly benign. And here you are stuck. Okay, and these are the cases you would again and again take back to the clinic and then arrive at the diagnosis. And if you compare this image, for example, do these cells match do these lesional cells match the atypia of that osteosarcoma? No, they are much lower grade. Okay, and then we discuss with imaging again, and then we arrive at the diagnosis of osteoblastoma. Let me tell you, this is a very difficult situation, not very easy as it is like sounding here in this meeting. Very difficult clinical scenario. Osteomas and osteoblastomas are morphologically similar,
I
although
think
they
we should
differ in
also
very.
take Madam Prakash opinion also what he will do when we are actually not concurrent with each other and probably not concurrent with sometimes with Prakash also.
Right. Yeah, that's a good question, but then it requires a very long answer. But Prakash, can you take that?
Well, see the issue is this. No matter what Amit says, no matter what I think, the hard challenge is if the pathologist tells us we are seeing a sarcoma, and no matter what the radiologist feels or the surgeon feels, it doesn't matter. But the implication of that is huge, right? And like
Yeah.
I was thinking back, if I were a pathologist, the question that I'd be asking the tumor surgeon or the radiologist is this: like, uh, forget the nuances of it, like broadly. Is it coming from the bone? Is it coming from the soft tissue? Okay, so you clearly know it's coming from the bone. Then is it contained within the bone, or has it broken the bone? So clearly here, some part of it is broken the bone. Then you ask, well, did it expand the bone before it broke the bone? And you would say, no, it didn't expand. So if it didn't expand, it's something aggressive. If it did expand, it's something benign. And then you go back and ask, well, how long did the patient have these symptoms? If the patient comes back and says, well, I've had this for a year, then you know, oh, maybe this is something benign. Versus they say, well, all this has happened just in over a month, maybe 2 months. Then you know it's something more aggressive. And lastly, being affected, right? Talus. You think back and ask the team, well, how common is a sarcoma in the talus? And if you go back and say, well, talar sarcomas are extremely rare. And then you don't start thinking of something rare, you start thinking of something common. Because when it comes to treatment, if this were a sarcoma, you need an amputation. If it's something benign, well, you save the ankle. So the treatment and the impact on the patient's life is hugely different. But at the background, I'll start by thinking, well, if the patient has had it for 6 months, it's in the talus, it's expanding some, and what are the benign bone forming lesions I can think of, and then we have our pieces of the puzzle put together. Over.
Right, yes. So there are the rational decisions to be taken at every level. And, this is a re-emphasis on how much onus lies on us. There is this immunohistochemistry for FOS that we can use in these difficult situations. We do not have it now, but if we have, we are hopeful that that might help. So this is how the FOS IHC looks like. It's a nuclear stain in one of the osteoblastomas. This is not my case. This is taken from internet. Okay, and FOS is negative in osteosarcoma. So if positive, it is hugely helpful in difficult scenarios such as that. Now, not all osteoid-producing tumors are malignant, and not all osteoid-producing lesions are even neoplastic. And one example of it is fracture callus. Okay, so the presence of osteoid or osteochondroid matrix just indicates that the lesional cells are of osteoblastic lineage. The diagnosis of malignancy is to be decided by cellular characteristics and not by the matrix. That is what I have just reiterated. This is a 14-year-old girl with a soft tissue tumor in the thigh, and there is no bone involvement. And this is how the lesion looked like. What can you see here, Pradhan? Can you describe this? There is no bone involvement. This is a soft tissue lesion. Pradhan, are you there?
Well, it looks like monomorphic spindle cells, and there is some bone actually. I don't know whether it is zonal calcification.
No, that's fine. So Srilata, are you there? I'm just calling out the students who are supposed to answer questions.
Yes, ma'am. We have bony trabeculae, like trabeculae which are partly mineralized, and in between we have spindle cell proliferation.
Okay.
Like
So there
at
was
the
some word
mostly in the periphery
said.
we have spindle cell proliferation, ma'am.
Yeah, so this is a pretty organoid zonated type of ossification that is happening in this lesion. Along with that, there is florid spindle cell proliferation at the periphery, and this is the higher power. So if this is a myositis ossificans, which is happening in the soft tissue. So it has this ossification and a spindle cell proliferation, which is essentially myofibroblastic in nature. Now I'm showing this high power to you. If you look at this without a context of that whole lesion, okay, and also the radiology, the location of the tumor being in the soft tissue, this can easily pass off as a sarcoma. Okay, and you might ask, oh, is it a bone tumor? It looks like osteosarcoma to me, and nobody would blame you if you call it osteosarcoma with this picture on microscopy. But then never forget the clinical context, never forget the radiology. So, and look at this part of the tumor. It is like so cellular, and the cells do have atypia, very blue looking. So if you lose the sight of the entire bigger clinical picture and focus only under your high power lens on the microscope, you are in big trouble. Okay, so this is a myositis ossificans. Why am I showing you this? Because this is a lesion which contains osteoid matrix and also bone formation, which is a conspicuous part of this lesion. But this is an intramuscular tumor. Okay, it is a rapidly growing lesion. There can be history of trauma. This can happen after even elective surgeries, burns, and also after neurological injuries as well. And diagnosis wise, they are very challenging, especially in small biopsies. They can be easily mistaken as sarcomas. Okay, if not the bone sarcoma, if there is a only spindle cell component in the biopsy, you might just call it a spindle cell sarcoma. So it is a challenging diagnosis, and it features as one of the topmost examples of pseudosarcomas, myositis ossificans. Okay, so this has a USP6 rearrangement. Now the problems in the diagnosis of osteosarcomas are many fold, and we are obviously not going to talk about all of these because this itself will take a lot of time. The problems are twofold. One is that OGS itself has got a lot of variants, and then there are so many mimics of OGSs which are not OGSs, like other tumors, then fracture callus, which is not a tumor at all, Ewing sarcoma, a round cell morphology, giant cell tumor of bone, chondroblastomas, chondromyxoid fibromas. All these tumors have the capacity to mimic osteosarcoma, and the other way around. Osteosarcoma has the capacity to mimic every of this tumor that is mentioned here. Now, there are so many variants of osteosarcoma. This is the most dreadful tumor when it comes to the diversity of morphology. And I honestly believe that it beats even melanoma when it comes to morphologic diversity. Okay, let us see a few examples of it. Each variant of this osteosarcoma is a diagnostic challenge because of the morphologic resemblance to either a benign condition or to some other malignant tumors, right? Now, this is a tumor. This is a biopsy. What do you think this biopsy shows? Krishna Priya, are you there? This is a genital
Yes,
biopsy.
ma'am.
I will tell you the details later. Just let us read this biopsy. And let's presume it is a bone tumor.
Ma'am, we can see
So
heaps
what
of
did I tell you?
spindle
The
cells.
approach. Yeah. So what did I tell you? How should you approach a bone tumor?
Tumor is producing any matrix or not?
Matrix.
If it is
What is
producing
your answer
matrix,
then?
there is a chondroid matrix you can see.
Where?
Ma'am,
See, chondroid, when you say chondroid matrix, it has to be a very firm and thick chondroid matrix, okay? This is more of a myxoid material.
myxoid type.
Yeah, this is myxoid material.
Myxoid.
And it is looking blue, so you might use the word chondromyxoid, but it is not chondroid in its truest sense. Do you agree with that?
Yes, ma'am.
So it is not really a matrix producing tumor. That is myxoid material, yes, but neither chondroid matrix, not osteoid matrix. That is the first thing. Now, what is the cell type? You
Ma'am,
saw
cells look
some,
spindle cells.
spindle, yeah, they look spindle. They don't look like those round cells, polygonal cells with large nucleus and nucleolus, as you saw in the earlier images of classical conventional osteosarcoma. These are more spindly. Yes? So which category would you put it
Yes, ma'am.
into? Could it be a cartilaginous tumor? It's possible.
Yes, ma'am.
If cartilaginous tumors undergo malignant change, they become more and more myxoid and lose their differentiated cartilaginous matrix, especially chondromyxoid fibroma. Could it be? And this is the radiology.
Yes, ma'am.
So now, Dr. Amit will tell you what this radiology is telling you.
Sorry, madam, I missed the little bit of the earlier.
That's fine. So just this image. This image.
History? Okay,
Sorry?
the image only. Okay,
Yes.
fine. So what we are actually seeing it here is that it looks like it is arising from the bone. That is the first thing that we want to tell rather than the soft tissue. We will see that there is a periosteal reaction, and periosteal reaction, which is something which is very horizontal, and then there is a large soft tissue component also. So it is coming into the aggressive lesion. Now when we have perpendicular kind of periosteal lesion, something like this, we want to rule out whether it is we are dealing with osteo versus chondro, and I need to see whether the matrix mineralization is of which kind. Sometimes chondroblastic OGS and chondrosarcomas can be confusing, and If you do MRI, then we can actually differentiate between these two entities very easily. So my differential will remain osteo over the chondrosarcoma. That's how we will
Yeah.
say.
Absolutely. Yes, yes, that's completely correct. So this is now when you go on a higher power, you start to see that these tumor cells, which on low power could appear benign to you, but look at these nuclei, they're hyperchromatic. There is anisonucleosis. And that can be the first roadblock that if you don't pay attention to the cellular details, you might just call this a chondromyxoid fibroma, because that is how chondromyxoid fibromas look like. Okay, and here there is some, see here the osteoid matrix has started to come back. So this is a chondromyxoid fibroma like osteosarcoma. Okay, for a diagnosis which on our histology was difficult, but radiology has made it very easy, calling it first of all an aggressive or a malignant bone tumor. And for us, the categorization was easy because this is certainly not chondrosarcoma. Okay, so this was a chondromyxoid fibroma like osteosarcoma. Chondromyxoid fibroma is a benign tumor. It is an expansile destructive osteolytic lesion. There is narrow zone of transition. So this is one of the examples of chondromyxoid fibroma, which our case really did not resemble. So the radiology contributed quite a lot to the diagnosis, which was difficult because why? Because it did not have the conventional features of osteosarcoma. No conventional osteoid. The morphology of the cells was stellate and spindled and not those typical osteoblastic morphology. That was our problem. Okay. Now, coming to the SAT-B2 immunohistochemistry at this stage. What is SAT-B2? This is the protein which is expressed in all the lesions or tumors which contain osteoblastic differentiation. So this will be expressed in lesions like fracture callus, reactive osteoid in giant cell tumor of bone, myositis ossificans, which has lots and lots of bone, benign osteoid producing tumors like osteoblastomas, then heterologous ossification in reparative lesions, and other non-osteoid producing tumors. Okay, and of course osteosarcomas. So how does this help us? Okay, where is it useful? It is useful when we have to distinguish osteosarcoma with others from other sarcomas, and distinction between dense fibrosis and osteoid matrix. Okay, and especially like in this case, like CMF, like OGS, if this is strongly positive for SAT-B2, this is more in favor of osteosarcoma than in any other sarcoma. And even remember, even chondrosarcomas can show SAT-B2 positivity, so it does not help in this context as well. So this is the use osteosarcoma from other certain sarcomas and distinction from dense fibrosis and osteoid matrix. So what have we learned? That SAT-B2 does not distinguish between benign and malignant osteoblastic tumors. So there is essentially no substitute to multidisciplinary discussions, and not every tumor which contains osteoid or osteoblasts is malignant. Lesions with reactive osteoid fracture, you need to be extremely careful about fracture callus, giant cell tumor of bone, and aneurysmal bone cyst, which would contain abundant reactive osteoid. So you should not fall into that trap. Now let us describe this biopsy. Who would take this now? I haven't heard Pradhan. Is he there or not? Otherwise, I won't call out his name. Indrajit, can you take this? What can you see
Yes,
here?
ma'am. I'm just a second. Yeah, ma'am, I can
Just
see.
describe it.
Yes, ma'am, I can see a lesion, spindle cell lesion basically, arranged in fascicles.
Why are you saying lesion?
Um,
Do you think it is reparative, inflammatory? This is
it's
from
a
the
tumor
bone.
actually. It's a
It
tumor,
is a
ma'am.
tumor, yeah. It's so
It's a tumor.
cellular. It is very
Spindle
cellular.
cell, yeah, very cellular spindle cell tumor arranged in fascicles in the first image, and the second one.
Again, it is the high part of the same. I just wanted to highlight the cellular characteristics. So again, it is a bone tumor. Start with the matrix. Do you see any matrix?
No, ma'am.
There is no
Not a lot.
matrix, maybe some fibrosis. This pink material is fibrosis, but no osteoid and no chondroid
No
matrix.
experiment.
What is the cell type? Is it osteoblastic cell type? Is it chondroid? round cell tumor?
Ma'am, it looks bit round cell tumor. And then at low power
Really?
it looks
Why?
no,
Why
ma'am.
did you say?
Low power, ma'am, but it's a
No, no,
spindle cell
this
tumor.
is the cell. That is why I kept this image first.
It's a
Is this
spindle
round
cell
cell?
tumor. No, ma'am.
It is a
Spindle
spindle
cell.
cell tumor. Yeah, it is a spindle cell tumor, and this is the radiology. See, I mean, if you look at only the histology without any radiology image, you would wonder that this is something very low grade spindle cell tumor.
Cell tumor.
Okay. Although then on close look, you might see that there is some hyperchromasia, but again, not much of a nuclear atypia, not very many mitosis. But now this picture comes in front of you, and anybody can recognize that it is a highly destructive, aggressive bone neoplasm, right? But still, our problem remains that we are not seeing any metrics, we are not seeing any conventional osteoblastic morphology, and there comes the utility of this SAT-B2. You do the SAT-B2, you know you're the radiology, and then you know that this is a fibroblastic osteosarcoma. Okay, and now it has no resemblance to high-grade conventional osteosarcoma, and that is the problem. Okay, so don't, you should always know the spectrum of any given tumor as to what is possible in a given spectrum. So now this tumor, Srilata, what can you say?
Yes, ma'am. We are seeing tumor with cells showing little epithelial-like morphology, ma'am.
Yes, correct. You're very right.
And with intervening areas of hemorrhage are noted, and we are not seeing any giant cells, ma'am. And there is
Any
no
matrix?
matrix.
No matrix.
There
Yeah.
is no matrix, and
And
cells are moderately pleomorphic, ma'am.
yeah, there is an isonucleosis. Yeah.
Yes, ma'am.
And the cells have some nucleoli. Mitosis I do not see in these fields, and these are aneurysmal blood spaces. You
Yes, ma'am.
said about
Cystic change
image.
we can see, ma'am.
No, so the specific term that is used is aneurysmal blood spaces, secondary aneurysmal blood spaces. That's the terminology you should use in the context of the bone tumors. And now this is the histology. Okay, and Indrajit, would you try describing this? Where is it
Yes, ma'am.
located? Where is
Ma'am,
this tumor?
it's located in the metaphysis.
Metaphysis. Where is the
Diaphysis, sorry, ma'am.
Ah,
Diaphysis. Mainly in the
yeah.
diaphysis. Can see some periosteal reaction as well. Cortical erosion is also seen. And tumor seems to be infiltrating into the adjacent soft tissue a bit. And also I can see this.
What is the zone of transition?
Yes, ma'am. Wide zone of transition.
Wide zone of transition. So now you have to get this ratified from Dr. Amit. Dr.
Yes.
Amit, was this correct?
What was the issue, madam? Sorry, I missed it.
Indrajit tried to describe this, so I just wanted to. So that's fine. So it is a very aggressive bone
Yeah,
tumor.
it is having sunburst kind of
Sunburst. Yes, yes. So this is a
that is
sunburst
very aggressive form of
very
peristry.
aggressive. And so this could it be osteosarcoma? Although it's in the diaphysis, we know osteosarcomas happen most commonly in the metadiaphyseal region. So yes, it could be. So this tumor, sorry, yes. Yeah, it can be. You can see some mitosis here. So now this tumor doesn't have any osteoid matrix. It has its morphology more of towards an epithelioid morphology. And yet what we are seeing here is a strongly SAT-B2 positive. So this is a osteosarcoma without any matrix. So remember, osteosarcomas do not have to show matrix in the biopsy at least. So don't disregard, do not dismiss that this is not an osteosarcoma because there is no matrix. No, that is not absolutely essential. If it is there, it helps you to make the diagnosis, but if it is not there, it does not rule out osteosarcoma. That is the message from this osteosarcoma. Now, this is the tumor. If you look at this, it looks like a round cell tumor, like how Ewing sarcoma looks like. But this tumor is doing something very interesting. You see this pink material? This is actually osteoid. Okay, so it is forming these rosetoid formations. This is central osteoid and the cells are around it. It's a very beautiful formation which is not seen commonly. Initially, when I saw this case, I thought, oh, I'm looking at an Ewing sarcoma with neural rosettes, which are seen in Ewing sarcoma. But when we looked at it closely, it looked like this is a matrix. This is osteoid matrix, and that is when the penny dropped that we are looking at small cell variant of osteosarcoma, and this was the radiology. So, Amit, if I had a problem between Ewing sarcoma and osteosarcoma in this particular case, would you have helped me in this?
I will go for OGS because there is a dense osteoid matrix that is there. It is looking aggressive. And if we see matrix, then we call it as OGS. So we are not having any doubt regarding whether there is a osteoid is present or not. There is an OGS.
Correct.
What kind of OGS? Definitely, sometimes we are unable to see it. But TOGS is the one variant that we can easily identify on imaging.
Yes, but this is not telangiectatic. The problem here was that it had a round cell component. So our immediate differential diagnosis in this was Ewing sarcoma. And this was the case again. Thankfully, there was osteoid, but it may not be there again. And here we should resort to immunohistochemistry for both, not just the SAT-B2, but also NKX2.2. And this tumor was strongly positive for SAT-B2 and negative for NKX2.2. So this was a small cell variant of osteosarcoma. Now, who will describe this biopsy from the bone? Krishna Priya? This is a genital biopsy. So what I'm trying to tell you is that the without radiology, without clinical context, our histology imaging or histology images or pictures don't make any sense, or you can be on a totally wrong track. This is one such example. So describe this morphology. What can you see here? What are these? So this is a needle core biopsy, J needle. What are these? These are bone trabeculae.
That's matrix.
Yes, that is matrix, but in a very peculiar fashion. They are running like long trabeculae which are parallel to each other, isn't it?
Yes, ma'am.
Then what is happening in between those trabeculae? There are these spindle cells. Correct. So fine, there is matrix and then this spindle cell. Do they look malignant to you by any standards?
On the first impression, it does not look like.
No, not at all. It doesn't look malignant at all. I mean, if I'm looking at it without any context, I would say this is some benign fibrous lesion. That is as far as I would go. But then here comes the radiology. And what is this? Prakash?
So very clearly on the imaging. So does anyone want to take this up, the imaging?
Yeah, can anybody?
Like what do you see?
We can see a high-grade tumor, sir, which is seen in the metaphysis to epiphysis region, and we can see classic sunburst appearance here, and this periostral
So yeah, so I
reaction.
wouldn't call this classic sunburst. What I can say on this X-ray is that I see a big tumor, which is around the metaphysis. Probably I'm seeing it on the surface of the distal metaphysis, right? Now remember, this is a 2D image. Your surface tumor may seem like it's coming from the medulla, right? But you see this long frond lacy-like osteoid that you see on the periphery, which seems like it's arising all from the periosteum, right? And if you notice, the cortex within that seems largely intact. If you see the cortices on both sides, look how they seem unbroken, correct?
Yes, sir.
Which to me
Yes, sir.
suggests that a lot of this tumor is arising from the surface. Now, how would you know that? You will probably look at anteroposterior and a lateral X-ray. And when you put both these together, you will know, is it coming from the side, from the back, or sometimes when it's coming from all around, from the surface, you can't make out if it's inside the medulla or outside, which is where you need cross-sectional imaging. So all I can see on this X-ray is I can see a bone-forming tumor, a lot of osteoid, but I don't see any destruction. I can probably guess that this is a surface tumor. Is it a surface osteosarcoma? Well, maybe, but I would like to qualify this further with a cross-sectional imaging to know if this is something on the surface, going inside, or it started inside, coming outside. But looking at the intact cortex, I would bet this is beginning on the outside.
Right. So Prakash, I haven't put a lot of cross-sectional imaging in this case.
No
But
problem.
to carry forward, so to carry forward this morphology, so this morphology fits perfectly with that imaging, which is that of a surface osteosarcoma. And which variant is this? This is a parosteal osteosarcoma.
Parosteal.
Yeah, okay, this is a parosteal osteosarcoma, which, if you look at it without any context, looks literally like a benign lesion. And that is what I kept repeatedly saying, that unless you know the spectrum of all the conditions that happen, you won't be able to make these diagnoses. Okay, so this is nevertheless a low-grade variant of osteosarcoma, happens on the surfaces of the cortical bone or the cortex of the bone. It is very challenging for the pathologists because they are bland and spindle cells. They are associated with MDM2 amplification. And the impact of this diagnosis to the patient is that these patients usually do not receive any neoadjuvant chemotherapy unless there are certain aggressive radiology features and medullary involvement. Otherwise, these tumors are refractory to chemotherapy. And the morphology is totally different than the conventional osteosarcoma. This is what another example of parosteal osteosarcoma. See the long bone trabeculae containing literally benign osteoblast in within them. And then the real stuff is this spindle cell proliferation. So all that ossification that you saw on the X-ray was because of these bone trabeculae. And the cells remain in between. They are nicely nuclear positivity for MDM2 is seen in this. So this is a very useful stain because this tumor looks so benign on histology. So we should demonstrate MDM2 positivity in all parosteal osteosarcomas. Now, either Amit
I have
or
one question. I
Prakash.
have one question, boss.
Yeah.
So about that part, yes. So because I want to apprise how challenging this is for us to biopsy and hence for you all to report because it comes on the back of the femur. It's on the surface, it's around vessels. So we often don't get an easy target to biopsy. So it's a small biopsy often also on the surface because you don't want to go into the medulla. Now, I remember in many cases, we confuse or is there a cartilage cap that's on top of the parosteal osteosarcoma sometimes?
It can be, yes, of course. It can be actually a very dominant part of parosteal osteosarcoma. So it's not exactly an
Yeah,
organoid cap that you see in osteochondroma, but
exactly.
there can be a lot of cartilage, and it also looks benign. It doesn't look malignant.
Awesome.
So that is yet another confusing aspect of parosteal osteosarcoma.
Right.
Yeah.
Super. Thank you.
Yeah. So, Prakash, while you are on this case, can you also take on this radiology? This is now a
Yes.
55-year-old male patient with pain and swelling in the shoulder region.
Right. So what are the first things I'm thinking? I'm thinking, oh, it's 55. It's on the humerus. Is it on one edge or is it in the center? It looks like it's on one edge, which we would call eccentric. Then I'm asking, is this expanded the periphery a bit? Yes, its periphery is expanded a bit. Is it well marginated? Yes, I think I can see a very distinct rim which is separating the lesion from the bone. So first instances, what am I worried about? Am I worried about something very aggressive? Probably not. Am I worried about something intermediate or low-grade tumor? Maybe. So these are the first thoughts. Is it producing matrix? Yes, I can see some osteoid. Is it with some chondroid? I can't make that out very clearly on this X-ray. But if I were to bet, I would say some fluffy osteoid in there, a bit trabeculated. So overall, I'm thinking maybe, or this is a benign lesion with some osteoid matrix, eccentric. But remember, when it comes to 55, is it a very common age for them to get a benign lesion in the shoulder? No. When we get a focal lesion above the age of 40, we immediately start thinking, is it a metastasis? We always rule out a metastasis over the age of 40, 45 for any focal bone lesion before thinking it's a primary tumor. So we'd work them up in that line. And then, of course, this MR, which is on the right, is a surprise
Yeah.
because it's not completely matching what I see on the X-ray, because
Okay.
it's showing a huge lesion which is on the surface, a big soft tissue component, which I couldn't appreciate on the X-ray. I can see an intact cortex, and I'm not quite sure if that marrow within is continuation, because you see a very bright T2 bright lesion, which is all cartilaginous on the surface, and
Yeah.
some dark areas within the marrow. So the surface one, which is T2 bright, I'll be thinking, well, this looks like a chondroid neoplasm if
Yeah.
this is T2.
Yeah.
And if this is a chondroid neoplasm on the surface, I'm thinking a surface chondroma, a periosteal chondrosarcoma. I'm not sure. And then if it has a medullary invasion, well, I'm leaning more towards then a chondrosarcoma at 55. Over.
Yes, yes. Thank you. Thank you so much. So the imaging, both X-rays and Prakash, it is possible that these two images are not of the same patient. I
Yes,
don't
it
think.
seems like it is two are different ones.
Yes, they are different.
Yeah,
But
different
what is
patients.
both are what we are telling, what we are gathering the information while we are looking at the biopsy is that we are dealing with a cartilaginous lesion even before we are looking at the biopsy, right? And now here is the biopsy. Now, what do you think here? Krishna Priya, can you just describe this? Now we just saw how osteoid matrix looked like and how osteoblasts look like. How different is this? What tissue will you call this? And you just heard the radiology. Is anybody there? Can you talk?
Yes, ma'am. Ma'am, as sir rightly said, on MRI, it looks like a chondroblastic tumor. As we can see on the HE stain, it is clearly a chondroblastic tumor.
Yes,
with,
yes.
there's no doubt about that. Lots of chondrogenic matrix, as well as like many cells with binucleate morphology. A lot of atypical chondrocytes are seen as well.
Yeah. So there are
Yeah,
these
it's
lacunae.
yeah.
Why do you recognize its cartilage? Because there is this typical blue cartilaginous matrix. Yeah. So the chondroid matrix, and that is what I was referring to in the earlier case. Then there are these lacunae of wherein you can find these chondrocytes. Some lacunae have two cells, some have one, but then this nuclear atypia is glaring. And remember, in chondrogenic tumors, you will never find an atypia in the league of osteosarcoma. And that becomes our struggle when we encounter the chondroid lesions, because the moment you start seeing so much of atypia, this is a straight away a grade 3 chondrosarcoma. You don't have to worry about it, but anything which is less than that, you have to struggle because it still can be a chondrosarcoma. Like here, believe me, this is a grade 1 chondrosarcoma which showed permeation into the bone. This is grade 2 chondrosarcoma, which started to see myxoid matrix, and this is a grade 3 chondrosarcoma, which is showing still chondroid phenotype or chondroid matrix and the chondrocytic morphology, as I can say, but look at the nuclear features. There is marked nuclear atypia. And even if you see a single mitosis in this biopsy, that this becomes a grade 3 chondrosarcoma. Because this tissue, chondroid tissue, is inherently slow growing. So the tumors also replicate the same biology of inherent chondroid tissue. They are slow-growing tumors. You will not find so much of atypia. Whereas on the other hand, osteoblasts themselves are metabolically so active. They are so functional. So that is also reflected in the tumors that they arise from, right? So
Yes, ma'am.
yes.
Yes.
So, chondrosarcoma, as compared to osteosarcomas, they are the tumors that occur in elderly age group, more often in long bones, but again, pelvis, ribs, and sternum are also important. It is very important to demonstrate host bone permeation, especially in chondrosarcoma grade 1 or what we call as a typical cartilaginous tumor in the peripheral bones. And this in itself is a very vast subject, but the issues with chondrosarcoma or ACT grade 1 is you need to demonstrate the permeation of the host bone like you can see here. Otherwise, you just simply cannot make any diagnosis. Now, this is the radiology we have, and this is the biopsy we have. What do you make of the biopsy? Prakash would say, I don't require your biopsy diagnosis. This is a frank chondrosarcoma on even X-ray. Okay, I don't even need the MRI, maybe it is so classic. But then look at this biopsy, how we are struggling. First of all, it is extremely well differentiated. It is the cellularity is just marginally increased. You would wonder, is it really increased or no? There is no atypia. There is no host bone to demonstrate that this is an invasive cartilaginous tumor. And you do not know whether this is an enchondroma or this is a grade 1 chondrosarcoma. And you are absolutely stuck. You go back, you tell everybody to look at the radiology, and this is the radiology. So, Prakash, now what will you take and what will you leave? You will take the radiology and leave the histology in such situations. Difficult, I know.
Yeah,
Very difficult
yeah,
and perpetual situation. There is no clear
yeah.
answer.
But in fact, it will be very instructive, I think, to share with the entire group a consensus meeting that we had last year for
Yes.
chondrosarcoma
Yes.
across the world,
Yeah.
where we had these
That's what
exact
I
same
want you to
problems
show.
because so now across the world, most groups which deal with chondroid tumors coming from the bone are moving towards triaging two things. One, when you look at an X-ray, triaging, does this need an MRI? And if you need an MRI, does this need referral to a tumor specialist team or not? And why is that? Because there are many features on imaging which tell you this is low grade, leave me alone. And there are some which clearly tell you this is high grade, you got to operate them. When I look at this X-ray, like man rightly said, you don't even need an MRI. This is a screaming chondrosarcoma. The site, the amount of soft tissue, if you look at the extent of the mineralization, the chondroid matrix, all of that is screaming at you saying this is a chondrosarcoma. And today, most tumor centers wouldn't biopsy these at all. You would do an MRI, and if there are classic features, you would label this as an intermediate or a high-grade chondrosarcoma, and you will resect these. There's no chemotherapy, there's no radiation. And why this is the example, because you biopsy and it's heterogeneous, you may have targeted the low-grade component. Because you have not gone through the medulla, you can't see permeation. You just have the soft tissue. All you know is there's something chondroid, you can't grade it. And there is great inter-observer variability. It depends on where you target. In the past, we would do a PET CT, see where the highest SUV is. But PET CT in most individuals, especially, this is not necessary at all because it's screaming chondrosarcoma. And this is the exact reason why people have moved away from biopsying chondroid neoplasms. Over.
Yeah, I'm so happy about it, honestly speaking. Right. Now, this is one example of a dedifferentiated chondrosarcoma. So you can still see a part of a high-grade chondrosarc here, and then you see how it is suddenly bursting into a high-grade pleomorphic sarcoma. So, yes, so very high-grade, no matrix. So this is how the dedifferentiated chondrosarcoma looks like. This is one of the examples of dedifferentiated chondrosarcoma. Now, this is a 14-year-old female, has a very well-defined epiphyseal lesion in the humerus. Yeah, is it Lytic? Prakash, can you say it's Lytic?
Right.
So
Lytic.
so it's like a bossulated, right? And if you look at this, as you rightly said, it's coming just around the epimetaphysis. Now it looks like a big, well circumscribed lesion, well marginated lesion that's just sitting on top of the humerus, right? And immediately this tells me, is this an osteochondroma? Is this like a sessile osteochondroma? And you would turn and take a lateral view. And sometimes you'll see this little stalk,
Stop.
which makes this entire osteochondroma, the marrow continues with the bone. And that's the hallmark, which tells you it's an osteochondroma. And oftentimes, if it's clearly an osteochondroma on X-ray, we wouldn't do an MRI. In the doubtful cases when an MRI has been done and it has all the classic features of some thin cartilage cap on top, mature bone, a mature stalk, marrow continuity, we wouldn't biopsy them. Okay.
Yeah.
Only if there are atypical features which come a little later, all of these will grow with the individual. Now she's 14. She's just beyond the peak because in girls, menarche is the peak growth velocity. So after 11, 12, the growth steadily comes down. The osteochondroma will grow with me. And at 18, it'll stop growing. So if someone at 25 or 30 comes and tells me, well, I had this osteochondroma, it was stable all these years, but now it's suddenly grown. You worry if there is a secondary chondrosarcoma arising in an osteochondroma. So most osteochondromas, you wouldn't biopsy. You will probably get it by mistake. Later in
Yeah.
life, when it's on the top of an osteochondroma, it's a low grade, likely low grade secondary chondrosarcoma.
The only issue that I think in this, it looks like it is arising from the apophysis. And then there is a very dense solid periosteal reaction that is accompanying it. So I don't know whether we need to do an MR just to rule out one of the possibilities of
100%.
chondroblastoma.
Yeah.
That might be one of the possibilities. And if there is a lot of edema that is there, then this could very
Yeah.
well fit also into the chondroblastoma also. So it looks like
Yeah.
cartilage, but it could be chondroblastoma also.
And
I
that's
see.
where
Okay.
history is important because does this girl have pain? Chondroblastomas, when they are edematous, have a lot of pain. An osteochondroma will just be a bump. It may not be painful at all, right? And that's where history matters. And as Amit rightly said, if it's painful, you would think this is a chondroblastoma.
Yeah, very useful hint actually. And so this is the biopsy. This is the biopsy, and this is a classic chondroblastoma, which is actually can be a great mimic of osteosarcoma. So this, what is this then? What are you seeing here, Srilata? What are these things? These are specks of pericellular calcifications.
Classification.
Okay, and then this is the chondroid matrix, and these are lesional cells. Let us look at them. So this is the lesion, okay, and we have the radiology, we have radiology opinion. So it's a cartilaginous lesion on radiology, definitely. So differential diagnosis, osteochondroma, chondroblastoma, and then you see this, it becomes a clear, crystal clear that we are not looking at osteochondroma, and this is a lesion which is not a conventional chondroid lesion. Can you see any conventional cartilaginous matrix? No. There is this pericellular calcification here, and then you are finding these coffee bean-like nuclei, which are so classic of chondroblastoma. Okay, so this is a great, it's a chondroblastoma which is dog1 positive, and this also has a histone positive, which is H3K36 or 35. And 96% chondroblastoma show this positivity. It's a great adjunct to the diagnosis of chondroblastoma. And trust me, this can be a very, very big trap in the diagnosis of bone tumors because it can mimic osteosarcoma quite closely in some cases. In fact, chondroblastoma, like osteosarcomas, is a debatable entity. Okay. Now, this 14-year-old female patient, she came with knee pain, and on this X-ray, somebody suggested osteomyelitis, but then this was the PET scan, and you can see that it's a huge soft tissue mass with the involvement of the cortex of the bone as well. This is the biopsy. So who will describe this biopsy?
We are able to see round blue cell tumor, ma'am.
all two cells are seen here.
Great. I'm so happy you could recognize the round blue cell
Round blue cell
tumors.
tumor.
Is there any matrix?
And
Oh, no, ma'am.
no matrix, ma'am. Some rosette formation occasionally.
So rosette, but no chondroid, no osteoid, no chondromyxoid. Yeah, very little fibrous tissue. And essentially, the cell type is that of a malignant round cell tumor. So, what are the differentials of a malignant round cell tumor in a bone? In a, how old is she? 14. In a 14-year-old.
First differential will be, ma'am,
Ewing
Ewing sarcoma.
Ewing sarcoma.
Ewing sarcoma. That's the
Small
commonest. Very
small
good.
cell
Very good.
osteosarcoma.
Small cell osteosarcoma, yes, we discussed that, and that becomes a now there is actually a lot to discuss on radiology as well, but we are running short of time, so we'll just move ahead. Yes, then what else?
Lymphoma
Then
less likely, ma'am.
less likely. I'm not asking you about in this case. I'm asking you about differentials of round cell tumor in the bone. The moment you utter the word Ewing sarcoma, the next differential should be that of a lymphoma.
Differential.
Okay, at any site, be it soft tissue or bone, lymphoma should be your immediate differential diagnosis. And then obviously a small cell osteosarcoma in this age group.
OGS.
OGS, small cell OGS, yeah. So this is NKX 2.2 nuclear positivity. And what is this marker for? This is a specific marker for Ewing sarcoma. Okay, so strong nuclear positivity and lymphoma markers were negative. And this is what is NKX 2.2. It is a specific marker with some caveats. So it's very important to distinguish Ewing sarcoma against lymphoma. I wouldn't say so much of osteosarcoma, but because there always are certain features that tell you that this is not Ewing sarcoma and this is osteosarcoma, but do not miss a lymphoma against an Ewing sarcoma, because the treatment is entirely different, the prognosis is entirely different. And this is one category of tumor, round cell tumors, where you have to consider all the differential diagnosis and appropriate IHC panel has to be applied. Okay. Now, this is another tumor, 30-year-old lower end of femur. What can you see here? What is the cell type? What matrix?
Focal entrapped bony trabeculae are there, ma'am. And these are also cells with high NC ratio.
Yeah, so again, this is a round cell tumor. Yeah, this is a round cell tumor, but what you can start seeing here is these are islands of cartilage. So a round cell tumor that looks like Ewing sarcoma but has cartilage, what is it? This is the histology. This is the radiology. This is a mesenchymal. Yes, yes. Have you ever seen this tumor?
No.
Yeah, they are more common in head neck region, but can also happen in long bones, and they are associated with this typical fusion, that is A1 and COA2. It is characteristic. So it does not share the molecular genetic signatures of Ewing sarcoma. Their prognosis and the response to chemotherapy is also different than Ewing sarcoma. So you have to diagnose this condition correctly, but it can be difficult in case you don't have cartilage in the biopsy. The reason is these tumors are also NKX 2.2 very strongly positive. Okay. Now this is a shoulder swelling. My God, we are running really late today. This is a shoulder swelling, so I'll be very quick. It is osteolytic, it is epiphyseal, expansile, eccentric, subarticular, non-sclerotic margins. And what is this now? You tell me, what is this?
Multinucleated giant cells.
Osteoclastic giant cells.
These are osteoclastic giant
like
cells. So, and what else? Only giant cells? There is something in between as well, correct? So there are these mononuclear cells. This is a giant cell tumor of bone, which has a classic picture of giant cell tumor of bone. You have almost uniformly scattered osteoclastic giant cells and the intervening mononuclear stromal cells. So this is yet another picture of giant cell tumor of bone, a classical one. This one has secondary aneurysmal bone cyst-like areas. Okay, so these are benign but locally aggressive bone tumors. They occur in the epiphysis of skeletally mature individuals. That means the physis is closed, and we have this classic histology. And then this histone H3G34W is seen in about not 90, maybe 95% of giant cell tumors, and a very useful immunohistochemistry marker because there are other differential diagnoses as well. Now, if you think about the giant cell containing lesions of the bone, it's a long, long list. So many reactive conditions, so many benign tumors, so many malignant tumors contain giant cells. So they are essentially a reactive or a reparative component of the whole ecosystem. They are not real tumor cells. Okay. Now, one condition which is aneurysmal bone cyst. So this also contains multinucleate giant cells. This will have, obviously by the name goes, aneurysmal blood spaces. This is the blue bone that is seen in the ABC. Okay, so these tumors or these lesions are associated with USP6 translocations. Now, why I'm showing you the ABC is because there are so many bone tumors which show secondary ABC-like areas, and out of which the important ones are giant cell tumors, telangiectatic osteosarcomas, osteoblastomas, chondroblastomas, fibrous dysplasias, and angiosarcomas. Each of these, as we have just discussed, have a very classic morphology of their own, but the presence of ABC-like areas can just dilute their morphology, and they also have their own histologies, but it can be diluted because of the presence of secondary ABC-like areas. Right? It's a common dilemma, like ABC versus GCT is a common dilemma. What do? You resort to ISCs in such cases. You look at the radiology again, and the H3G34W gives you a definitive diagnosis of so I think I will just move ahead very quickly. So what do you do when you have lot of giant cells and lot of ABC-like areas? So the rule of thumb is just view from your visual field, filter out these ABC-like areas. You filter out the osteoclastic giant cells. Focus on the legional cells. Okay, the beasts within, those are the ones which drive the lesion, and those are the real character of the lesions, not the giant cells, not the aneurysmal bone cyst-like area. That is all just drama. Okay, the real lesion lies in between these things. So focus on those. Then get back to radiology. Apply appropriate immunohistochemistry. And remember, in these distinctions, ADB2 really may not have any value, but the histones do have. Okay, so that is the message about lesions which contain aneurysmal bone cyst-like areas or even osteoclastic giant cells. And don't let these two features obscure the real nature. Okay. So a quick reference to multifocal bone tumors. When it comes to multifocal bone tumors, the radiologist would just utter two words in one sentence in single breath, and that is metastasis myeloma. So they really like to call them met myeloma. Yeah, multifocal lesions, but there are other lesions which can be multifocal lymphomas, vascular tumors, histiocytic lesions. What is this? Spot diagnosis? Quick. We
Uh,
don't have much time.
Metastatic
Metastasis.
Which one? Which metastasis?
from thyroid, follicular carcinoma.
Thyroid follicular.
Out of
Excellent,
thyroid
excellent.
follicular cells.
Right. I mean, even if there is no history, you would be able to call it very confidently because this just looks like thyroid. Okay. This is a follicular thyroid carcinoma. Okay, now adenocarcinoma in the bones can come from anywhere. Like this is a signet cell adenocarcinoma, this is prostatic adenocarcinoma. The onus on the pathologist, and especially in this era of targeted therapy, is to find out where the tumor is coming from. So remember, all metastatic adenocarcinomas, you should apply at least a minimum panel of ISCs where there is unknown primary, right? These are the most common sites. So you should know where the common sites, where the tumor can be coming from. Now, prostate, kidney, breast, thyroid, lung. These are the commonest carcinomas which go to bones. So think about them first. Apply immunohistochemistry if it is a disseminated bone metastasis and with unknown primary. It happens more often than not. The patient presents with bone metastasis thinking that it is a bone lesion, but it's apparently it doesn't turn out to be, right? And obviously there is a workup for myeloma. So take into consideration everything. Look at the morphology to appropriate IHCs. If it is myeloma, it is very apparent on morphology that you are looking at a plasma cell myeloma. So apply kappa and lambda. Otherwise, it becomes a different immunohistochemistry panel if it is a carcinoma. I think we should stop here. If there are any questions, we can take it. This was one nice case of adamantinoma that I wanted to show. This was one case of a chordoma that I wanted to show, which shows EMA positivity and brachyury positivity. Yeah. So just to summarize a few points, diagnosis of all bone tumors should be made along with clinical and radiology inputs without exception. However clear the diagnosis of osteosarcoma or even sarcoma is under your microscope, you have to look at the clinical picture and the radiology picture. Pathologists should be well versed with prognosis and treatment implications of the diagnosis. They should know what the impact of this diagnosis is going to happen. You cannot, as far as possible, avoid giving the differentials of a benign condition and a malignant condition unless you are literally pushed to the wall. We end up doing that, but it is a very unhappy situation, right? So understand that what is that differential diagnosis going to happen? What is going to happen to that patient? Okay, what decisions are going to be taken finally? OGS is the greatest mimicker of all tumors, I would say. Histologic features of bone destructive lesions and cellular atypia, atypical mitosis are most important and not the matrix, not the giant cell, presence of giant cell, not the presence of aneurysmal blood spaces. What defines a lesion is the cells that they are. Okay. Now, a lot of conditions can mimic osteosarcoma. Be aware of all these conditions, like starting from fracture callus, then myositis ossificans, and certain benign bone tumors. So the message is that this journey through the Haversian canals in the bone is very treacherous for everybody. So the key is you should stay connected. The only way is to stay connected so that you do not fall into any traps, do not get lost, and do not harm the patient. That's most important. And when you are reporting a histology, this is the report. If I ask Prakash to read this report, Prakash, would you be able to make any sense out of this? Just let us read this loud. Okay, I am saying a tumor with sheet-like pattern containing large cells with abundant eosinophilic cytoplasm, nuclear pleomorphic, abundant hyaline material is seen, mitosis are present. Full stop. Does it
Yeah,
make
I
any
think,
sense?
well, it may make sense, but it's lacking context. So if I were
Yeah.
sitting with you, looking at the slide
Yes.
when I've already seen the X-ray and the image, then maybe it'll make more sense. But right now I'm missing all context. So I would be like, I don't know what to make of it.
So even if there was a context, is this a complete report? There is no
No, it's
diagnosis.
not. It's
There
not.
is
Because in
just
the
the
end,
description.
yeah,
Just the
yeah.
description. It is not a clinically meaningful report. So the message to all the residents who are listening is that you have to have your description ready in your mind and a relevant description on the paper, but always make that observation, that description clinically relevant by offering a wholly integrative diagnosis, right? So we are friends forever. So this is maybe me and Amit, and there should be Prakash here as well. But I'm closer to Amit, Prakash, when it comes to
Yeah,
diagnosis of bone tumors.
yeah, absolutely. Absolutely.
I know, but it is a whole integrative exercise, there's no doubt. So thank you so much. Thank you for being here. Are there any questions? Sorry, I had to rush in the end, but
Thank you.
We learned some pathology actually, and some little bit of information from Prakash. I know
likewise.
we very difficult to catch hold of Prakash, na? So this time we got it.
Okay. So any questions? Are there any questions, Ruchi?
Ma'am, parosteal osteosarcoma versus periosteal osteosarcoma.
Okay. So periosteal osteosarcoma is essentially a chondroblastic osteosarcoma. It shows it's very different morphologically from parosteal osteosarcoma. It will show just differentiated cartilage. So you can equate it to maybe a grade 2 chondrosarcoma with some osteoid matrix as well. So, but again, it is also a surface tumor. So when it comes to surface tumors of the bone, you can have many tumors, and within the category of osteosarcoma, you have parosteal, periosteal, and high-grade osteosarcoma. Even high-grade
But I think
osteosarcomas.
very dense and classically located in the posterior aspect of the femur, and it is centrally very dense. One can actually think of if you are having a doubt versus periosteal and parosteal, I think you favor parosteal. Periosteals are, well, like Madam said, it is cartilage in origin, and that's why it is more lucent and it is much more aggressive variant as compared to this. I think Prakash can add on that. And definitely we have circumferential involvement. It is more towards one side, whereas the periosteal is involving a more larger part of the bone. Prakash, you want to add something on that?
I agree with most of what you said, because I think they have a fundamentally very different radiology to begin with. And parosteals are at the back of the distal femur very classically. The periosteals have a very different radiology. So when you look at both of them, the clinician, the surgeon and the radiology team would probably be able to tell you, is it more parosteal or is it more periosteal on the imaging? And then you could put one and two together. But how they look differently under the pathology slide, I don't know. I'd be happy to see so many more pathology slides of periosteal, of parosteal. And I was thinking, maybe it will be a great idea next time where we have like a live thought process of how Dr. Mukta thinks through a case where she's put the first slide in, and this is what you're seeing. And how do you go through the different heterogeneous areas of a biopsy that you get? How do you decide if there is matrix knot, what kind, what IC you would do, and then arrive at a diagnosis? I don't know if there was periosteal versus parosteal directly in this slide. In this presentation.
Yes, we can. So yes, so just likewise, the histology of these two are also fundamentally different. One is entirely a cartilaginous tumor. And another is just like as you saw here, this is a it looks like a fibroosseous tumor. So very different histology. Anything else, Ruchi?
No more questions in the chat box, ma'am.
Oh, great. Thank you so much. Thank you, Prakash, and thank you, Amit.